Hi, I'm Dr. Brittany Todd. I am a pharmacist and a mother, and I just did a birth control series that went into the history of birth control, side effects, how birth control works, who takes birth control for other reasons, and I kind of went into a little bit of surrogacy and IVF and the Catholic Church piece of it. But what I really want to do today is talk about the data supporting the ovulation rates that I had mentioned in the previous videos, because I know a lot of people say, well, maybe it's not my birth control, or I don't think my birth control is the one that relies on the secondary mechanism. So let me just remind you how birth control works. Hormonal birth control, let me specify which one we're talking about. Those are the ones that have estrogen and progesterone components. And some birth control has estrogen and progesterone, and some birth control just has the progesterone. And the reason for that is, like I said in the previous videos, I'm not going to go into the whole history of it, but when they found estrogen inhibits ovulation, it prevents women from ovulating, but they found that the high doses that it required to prevent ovulation completely was just not tolerated by women. They had a lot of side effects. They had nausea, breast tenderness, weight gain. They just didn't feel well. So then they dropped the estrogen dose and realized that women were still ovulating sometimes. So to counteract the effect of still getting pregnant on estrogen, they added the progesterone component, and progesterone makes the cervical mucus a little bit thicker, so it's a little bit harder for the sperm to swim up. It also makes the uterus, the endometrial tissue within the uterus, hostile, or it doesn't let it grow, right? Like in a normal cycle, when a woman ovulates, the endometrium starts fluffing up and getting nice and cushy and ready for that embryo so that it can implant into the uterus. Well, the progesterone component of birth control tells the uterus to not do that. So it makes it basically a hostile environment. So if an egg does get fertilized and that new zygote, new baby comes down into the uterus, it has nowhere to implant. So that's where the secondary mechanism of progesterone comes into play. So most contraceptives on the market have both. It has estrogen, which is supposed to just inhibit ovulation, and it has the progesterone, which is more of the cervical mucus and the alterations in the endometrium is what they'll say on the package insert. So the question is, how often does my birth control prevent ovulation? Like maybe you're on birth control and you're just hoping that 100% of the time it's preventing ovulation. Because if you think about it, if it's not preventing ovulation and you ovulate and you do fertilize an egg, you created life. And if you're pro-life, from moment of fertilization, that means that you are possibly impeding a life from implanting into the uterus. So if you think that that's still okay, you're not actually pro-life at moment of fertilization, you're pro-life at moment of implantation. There's a difference. So if you're pro-life, full pro-life, moment of fertilization, a new life begins to form, the cells start, splitting and growing and doubling in size as it's moving down the fallopian tubes into the uterus. If you are fully pro-life, there should be 0% chance of ovulation because you want 0% chance of fertilization. I hope that makes sense. So let's get into the incidence of it. As a Catholic, we think of different mechanisms altogether. We like the procreative aspect. We like the unitive aspect of marriage. So in the Catholic faith, even ovulation prevention within a marriage is not a good thing. But if you are pro-life and you're not Catholic, you don't follow our teachings, that's fine. But just know that if you are pro-life from moment of fertilization, you have a good 7 to 10 day window where you could be causing a problem that goes against your entire philosophy on pro-life. So let's talk about the data. So there are different kinds of birth control, like I said. There's combined oral contraceptives. Those are the oral, they're tablets. You take them by mouth. Combined means estrogen and progesterone both working together. And then there are progesterone only pills. We call them POPs for short. And that's no estrogen component, it's just progesterone. So the question is, how effective are they at stopping ovulation? That's what it says, that's what it claims, so let's get into it, okay? So there was a study that was done in 2008, and it was published in the Journal of Family Planning Reproductive Healthcare, and it was by Milsom and Corver, and they looked at ovulation rates on certain types of birth control, just the most common types of birth control. And they broke it down in the high dose estrogen, combined oral contraceptives with each progesterone component, because there's different ones in different pills. And then they broke it down into the low dose estrogens and their different progesterone components. And then they broke it down into their progesterone only pills. And then they broke it down into, there's IUDs or IUSs, those are intrauterine devices or intrauterine systems. So they reported on that. And what they said is they looked at a big database of different studies looking at different oral contraceptives, and they looked for ovulation rates. Did these studies look to see what the incidence of ovulation was on each of these birth control pills? And so they included the studies that had consistent ways of measuring ovulation or determining ovulation, and consistent studies that, you know, use the right oral contraceptives, use the right patient populations, those kinds of things. So they kind of narrowed it down to many, many different studies. And I actually can't remember how many studies they ended up including in this thing. Can't remember. It's in here somewhere. Anyway, I mean, I can look at this and I can see just in general, there's probably 30 studies for the combined oral contraceptives, another 30 studies for the lower dose, another 25 studies or so for the phasics, and then maybe another 12 studies or so for the progesterone only pills. So overall, there were probably 50 plus studies in this. And what they looked at were the studies would determine if the woman ovulated by two different mechanisms depending on the study. So one, they would measure the woman's progesterone levels post-ovulation time. So around day 18 to 21, they would start measuring progesterone levels. And an elevated progesterone level of 5, 9.6, or 16 millimoles per liter is what they said indicated ovulation. So if the progesterone stayed under those parameters, then the woman did not ovulate. But if they went above those parameters, it means that they ovulated. Or some studies actually did ultrasounds to look for follicular rupture to see if an egg was actually released. And some of them did both. So those were the methods of how they determined if a woman ovulated on birth control. So let's start with the combined oral contraceptives that were the higher dose. So these are the ones that have ethinyl estradiol at 30 to 35 micrograms and then a progesterone attached to it. Okay, so the high dose just is in relation to the estrogen component. The progesterone just changes the incidence of ovulation a little bit, but it's really the high dose versus low dose that we're looking at too. So overall, of all of the studies of the combined oral contraceptives higher dose medications, and let me give you an example of those. That would be the Avion, Seasonal, Jolessa, Apri, Enskice, Junel Effie, Sprintec. Those are very common ones. Sprintec, Apri, Avion, those are very common high-dose oral contraceptives. On average, of all of the studies that looked at all the progesterone levels and different progesterone components, if it was a high-dose estrogen pill, the incidence of ovulation was 2%, which means 2 out of 100 women ovulated on average. But it depends on the progesterone where you are in that average. The upper limit of normal, so there was one study that found up to 65% ovulation incidence. Let that sink in. That means that more than 50% of the time, the women ovulated in one study. Now, on average, the studies were all the way down to 2%. So obviously the 65 is like a super outlier, but it doesn't mean that it's impossible, right? And sometimes you wonder, well, why do women get pregnant on birth control? This is probably why. So then they broke it down, not just the high dose estrogen component, overall was 2% incidence, but they broke it down into each progesterone component. So if you're on a pill that has the high dose estrogen and levonorgestrel, the average ovulation was 2.2%, anywhere from 0.8 to 4.7% depending on the study, which means if you're on Seasonal or Avion, which are two very common high dose oral contraceptives, your risk is really like 2 to 4% ovulation, okay? If you're on gestadine as your progesterone component, you're basically 0%. But let me tell you something. As a pharmacist, I have never seen gestadine used in the United States. So we don't have the one that's 0%. Now, it's not completely zero. It averaged 0, but one of the studies did show up to a 1.3% ovulation rate. If you're on desogestrel, which is a pre, one of the most common, the ovulation incidence on average was 1%, and it went all the way up to 5.4% depending on the study. If they're on norethindrone, which is Junel FE or microgestin FE, which is also very common, their ovulation rate was 3.3%. That means 3 out of 100 women ovulated every month on those pills, with a range in each study from 0.1% all the way up to 17.2%. And then for norgestimate, which is also a common one, Sprintec is probably one of the most common birth controls out there. Sprintec has norgestimate, and its ovulation rate averaged 2.2%, but the studies went all the way up to 11.5%. So on average, if you're on a high dose estrogen oral contraceptive, regardless of the progesterone, on average 2.2% ovulation risk. But depending on the progesterone, that incidence actually goes up. So again, if you're pro-life, are you willing to accept a 2% chance of ovulation? That means that every 100 months, essentially, you could still be ovulating. All right, so let's go into the low dose oral contraceptives that are still combinations. So these are the ones that have 15 to 20 micrograms of ethinyl estradiol and then a progesterone added on. So in general, any low dose ethinyl estradiol actually has a lower incidence of ovulation, believe it or not, of 1.1% in the low dose. But the upper limit of normal in one of the studies went all the way up to 49.4%. So almost half of the women in that study ovulated. Now again, that was an outlier. The average was 1.1%. Now let's break it down into the different progesterones again, because that makes a huge difference. We already know that the gestadine is about 0% in the highs. It's the same as the lows. It's about 0%. Again, I've never seen a gestadine birth control in the United States. I don't even think we carry it in the United States. So the two main ones in the low dose estrogens are levonorgestrel and desogestrel. So levonorgestrel is probably the most common low dose, and that's Levlin and Losizanique. And that's like the one that you take for a couple months and then you stop, and then you take it for a couple months and you stop. And Levora. Those are the low dose, and they have levonorgestrel, and the incidence of ovulation in levonorgestrel with the low dose is 8.6% average. That's almost 1 in 10 ovulation rate. And it ranged from anywhere from 4% all the way up to 15.6%. So if you are on Levlin, Levora, or Losizanique, that's a levonorgestrel with a low dose estrogen, you have a significantly higher chance of ovulating on that pill. And then the desogestrel is another one. That's the Apri, the Cyclesa, Orthocept, Riclipsin, lower dose Apri. Their average was about 0.2%. So not a huge risk, but that's still 2 in 1,000. And their range was only from 0 to 1.1%. So the ovulation risk for those is actually very low. However, you want to ask yourself, are you willing to take that chance? All right, so then they broke it down into phasic combined oral contraceptives. These are the ones that change the dose throughout the cycle to kind of match what a normal cycle would look like. So on average, if you're on a phasic pill like Trivora, the incidence of ovulation was 4.6%. And it ranged anywhere from 7% all the way, or 6.7% in one of the studies, all the way up to 81.3%. But in another study, it was basically 0, which brought down the whole thing. So there was one study that showed 81.3%. Again, outlier. But when you start seeing these outliers in every single one, you start thinking, how often does this actually happen in real life? Think of the millions of women who are on birth control. How often does this actually happen? Okay, so average for a phasic like Trivora was like 4.6 for all phasics. But again, if you broke it down by progesterone component, it changes the risk. So levonorgestrel has an 8% risk of ovulation, and that goes all the way up to 12.7%. Gestodine, like I said, not here, is basically 0. There is up to 4%, but it's basically 0 on average. Norgestimate is 6.3% all the way up to 15%, but the average was 6.3%. Desogestrel was 0% average, but goes all the way up to 9.3%. And then norethindrone was on average 4.5%, but it goes all the way up to 22.8%. So there's ranges. What I'm giving you are the ranges, but also just the average. What the average ovulation rate for Trivora is 8%. That means that 8 out of 100 times, or almost 1 in 10 times, a woman can still ovulate. Per the data, not per me, per the data. Which means it's relying on that backup mechanism of making the uterus hostile and making the cervical mucus thicker so that one, the egg doesn't get fertilized, and 2, if it does, it doesn't implant. You have to ask yourself, are you willing to take the chance of still creating the life and just giving it nowhere to go? It's like putting a toddler outside and saying, sorry, the toddler died, but yeah, you put it in an environment where it's not going to grow. So how pro-life was that thought? So you have to think about that in the uterus as well. If you created a life and you gave it nowhere to go, that's not pro-life. Okay, so those are the estrogen and progesterone combined. So anywhere from like 2 to 8% depending on the low dose, high dose, the phasic, and what progesterone component you use. Now let's talk about the progesterone only pills. So the people who get the progesterone only pills are people who have contraindications to the other pills. And the question is, why are there contraindications? Well, because estrogen can cause blood clots. So if you are at risk for stroke, heart attack, blood clots in your legs, blood clots in your lungs, you're a smoker, you're over 35 years old, you have migraines with aura, and then you're not sure, are they having a migraine with aura or are they having a stroke? Well, they're on birth control, so it could be either one, I don't know. So what they do is say, you know what, you're at risk for these blood clots that we pretend don't exist in normal life, but if you're at risk, we're going to put you on a progesterone only pill. And they're very common to be on just progesterone only. So the average incidence of ovulation, if you're on a progesterone only pill, no estrogen at all, is 42.6%. 42.6% is the average ovulation incidence in progesterone only pills. Now again, they broke it down into, whoa, what progesterone are you on? So norethindrone, probably the most common progesterone only pill. Those are the orthomicronor, the Micronor, the Erin, Camilla, the Heather, all the ones that are named after girls, right? Norethindrone, on average, has a 34.9% incidence of ovulation, but it ranged in the studies from 24.9% up to 45.9%. That to me is no longer an outlier when the average is right in the middle of those. So 1/3 of the time, women on these traditional norethindrone pills, progesterone only pills, are ovulating. 1/3 of the time, which means there's a possibility 1/3 of the time that woman's getting pregnant. Okay, how about levonorgestrel? Levonorgestrel is Plan B or One Step. Those are the ones that you don't have a prescription anymore. They're actually over the counter. You can get them at a vending machine at a university I recently read. And you just take it if you have unprotected sex and want Plan B. The reason it's called Plan B is we didn't prevent you from ovulating, but we can prevent it from implanting. Here's why. 65.5% of the time, levonorgestrel, progesterone only pills do not ovulate or do not prevent ovulation. That means that 65% of the time, a woman still ovulates. More than half the time, a woman still ovulates. And the range is anywhere from 45% of the time. So like at least 45% of the time you're going to ovulate. And at most 82% of the time you're going to ovulate on that pill. Let that sink in. Levonorgestrel relies on the backup mechanism more than it relies on its preventing ovulation mechanism. That means that you can get pregnant more than half the time, but it's okay. We have a backup Plan B where you won't get pregnant. See what happened? What else is an levonorgestrone, progesterone only? Not just an oral contraceptive, but the IUDs. So there's an intrauterine system called Mirena and Kyleena, which are the two most common ones used here in America. And they're an intrauterine system. They're inserted into the uterus, and they kind of look like a, I don't know, like little antenna that go up in there, and they release this hormone, this levonorgestrel, and they have the same 65.5% incidence of ovulation, which means the intrauterine systems and devices are not relying on ovulation at all. They're relying on that backup mechanism. Let me read you the package insert for Mirena and Kyleena. They say it has several mechanisms that prevent pregnancy: thickening of cervical mucus, preventing passage of sperm into the uterus, inhibition of sperm capacitation or survival, and alteration of the endometrium. It doesn't even mention ovulation in there. It doesn't even claim to prevent ovulation because it knows that the majority of the time it doesn't even work that way. So it's not even in the package insert. Same with the Skyla intrauterine system, same with the Liletta, the Kyleena. They all don't even mention ovulation in the package insert for these intrauterine devices and systems. So that is a big red flag when you're taking those pills. So those are the traditional progesterone only pills. Average is 42.6%, but if you're on levonorgestrel, the average is actually 65.5%, right? There is one progesterone only pill, which is the desogestrel, that again, I haven't seen in the United States, and its incidence is actually 1.25% of ovulation, and it ranges anywhere from 0.03 to 6.8, so pretty low incidence on that one. But again, as a pharmacist, I haven't seen that one. The most common ones to me are the IUDs and Erin and Micronor. Those are the ones that we're seeing the vast majority of the time. So if you are on any of the pills that I mentioned, you know that your incidence, depending on which pill you're on, is anywhere from about 2% all the way up to 65% ovulation rate. What about so I mentioned the package insert for the intrauterine devices, the Mirena, the Kyleena, that don't even mention ovulation in the package insert anymore. What about the pills? Do they still mention it? And yes, they do. So let's go with Micronor, which is norethindrone. It says it prevents conception by suppressing ovulation in approximately half of the users. So it's actually pretty honest. It says that only about half of you will have ovulation prevention. It thickens the cervical mucus to inhibit sperm penetration, lowering the mid-cycle LH and FSH peaks, slowing the movement of the ovum, which is the egg, through the fallopian tubes, and altering the endometrium. Anytime you see something that says altering the endometrium, that means that it's relying on a backup mechanism, at least to some percentage, right? It might only be 2% of the time, but that means that it needs it there. Otherwise, they wouldn't have that progesterone component in there at all. So if you ever look at your package insert labeling and it says altering the endometrium, ask your pharmacist. They usually don't give you the actual package labeling, the prescribing information, but you can ask for it and you can open it up and you go to section 12.1. It's always 12.1. That's a mechanism of action. And if you see in there altering the endometrium or alteration of the endometrium or may inhibit implantation by altering the endometrium, that's what they mean. It means that if you conceive, it's okay. We made the uterus hostile. The baby can't implant. You're going to be just fine. Let's see. Nexplanon, which is a subdermal, the implant that goes in your arm, which I haven't seen in a really long time, but some people are probably still using it. That one says that it suppresses ovulation, increases viscosity of the cervical mucus, and it alters the endometrium. So if you ever see that, know that it needs that mechanism in order to be effective. If it didn't have that mechanism, we'd have women getting pregnant on birth control all the time. So just if you're pro-life from moment of conception, you should think, why is there that extra mechanism in there, right? So those are the mechanisms and the data behind all of these oral contraceptives. I didn't talk about Paragard, which is another intrauterine device. That one is not a hormone, it's copper, and it simply releases copper into the uterus, which is toxic to sperm. But it also, in the package insert, says possibly prevents implantation. Probably because it's making the environment toxic. It's copper. I'm not sure. It doesn't say. It's, you know, some of these say things like mechanism unknown, but it appears to alter the endometrium, it might say. So this one, you know, mechanism unknown, but possibly prevention of implantation. Now, I don't know, because it doesn't say in the package insert, and I don't see any data for it, that is it actually reducing the endometrial tissue like the other ones, or is it a toxicity? You know, if you have too much copper in the uterus, does the baby just die because there's too much copper in there? You know what I mean? That, like, it's a balance of chemicals, right? So that is, in a nutshell, the data behind how the birth control works and what is the incidence rate of ovulation. I kind of think of it, I tried to think of an analogy to use, because I think some people are willing to take the risk. Oh, it's only a 2% chance of ovulation. That means that I probably won't ovulate. But I've been trying to think of an analogy for years, and I've thought of, like, let's say you're going on to a game show and you are going to be blindfolded, you know, head cover so you can't hear or feel anything. And you're going to be put in a room, and you can be in a room on a bridge, you can be on the floor, you can be on the side of the room, the corner of the room, you could be up on the ceiling almost. They're going to put you in a room and you can't see or hear anything. You have no idea where you are in, like, this boxed room, right? And they hand you a gun. And they say, if you shoot this gun, we'll give you $1 million. But the catch is, we're going to put this 2-year-old somewhere in the room. And we're not going to say where you are. We're not going to say where the 2-year-old is. He could be above you. He could be in front of you. He could be next to you. He could be below you. You have no idea, in this giant cube around you, where this 2-year-old is. But if you shoot the gun, you get $1 million. The other catch is, we will never tell you if you hit the baby, if you hit that toddler. So you're going to shoot the gun, and you're going to be backed out of the room, and we're going to hand you $1 million. Are you going to shoot the gun, knowing you will never know if you kill the child or not? But you took the money, you took the lifestyle, you took the job because you didn't want to have kids yet. You took the cars and the travel because you weren't ready for kids yet. So you took the risk of ending a child's life because you wanted $1 million. Are you willing to take the chance? What if it goes up from 1 toddler to 70 toddlers? And you could shoot the gun anywhere in the room, and the chance of you hitting one is 65%, like the levonorgestrel progesterone only pill. Would you shoot the gun? You'll never know. You get $1 million. Would you do it? And I'm praying that the answer is no. I'm praying that you value the human life over the lifestyle that you're choosing by contracepting with oral contraceptives or IUDs or hormonal contraceptives, because you're putting a life at risk, and you might not know it, but you're doing it. I hope this was helpful. If you thought this was good, share it with someone that maybe doesn't know much about birth control or has argued back against birth control. I ask you, if you're interested in more videos like this, to subscribe and join my channel, like the button, send it to your friends. Thank you so much for listening. I truly appreciate this outlet and just getting the information out there to all of you.